Good morning. So I'm going to talk this morning about some common knee disorders that you guys see in your office on a regular basis. And the first thing I want to discuss is meniscus tears. And the meniscus is a fibrocartilaginous structure, and it does have important function in the knee. It provides for stability and acts as a shock absorber. So since it is very important for knee function, when we certainly try to preserve as much of the meniscus when we're providing care. The meniscus is certainly a common sports-related injury, and it usually occurs as a result of a twisting force. And these tears, too, can also occur as a result of repetitive activity or degeneration. And the patients that come to your office will complain of pain along their joint line. So if they have a medial meniscus injury, they'll have pain along the medial joint line. And they also may complain of catching or giving way. And swelling may also, of course, be present. This picture on the left is an example of a classic bucket handle tear. And this is a tear in which the meniscus is attached in the front of the knee and also in the back of the knee, and then the main body of the meniscus has been displaced into the inner aspect of the knee and in the notch of the knee joint. And these patients will present your office many times with a knee that they can't bend or extend or place weight on. And this kind of a tear is something which you should probably, this patient should have this treated in a fairly timely fashion, since these many times can be, these menisci can be salvaged and repaired. Whereas if they're allowed time to pass, then the meniscus can be macerated and the meniscus then cannot be salvaged. Now, some meniscus tears certainly can heal without surgery or become asymptomatic with time. So if a patient's having minimal problems, you might want to treat them with a short course of anti-inflammatories and physical therapy, and they may then not require anything to be done surgically. But if the patient is active and young and has a meniscus tear such as this type of tear right here, which obviously causes mechanical problems, this probably needs to be treated with either meniscus resection or repair. Now, the other thing to keep in mind, though, is that meniscus tears in elderly patients are many times just an incidental finding, and they're associated with osteoarthritis. So the cause of the patient's symptoms is probably the arthritis and not the meniscus tear. And the indication for surgery in that particular instance is really if the patient is having mechanical symptoms of catching or locking or giving way. So certainly when someone comes in, an elderly person, you suspect they've sustained a meniscus tear and they have associated arthritis, usually I'll go ahead and inject this with corticosteroid and maybe treat them with a short course of anti-inflammatories or physical therapy. So the clinical exam for meniscus tear, it's pretty straightforward. Patients generally have joint line tenderness, so if they have a medial meniscus tear, they have tenderness along their joint line. And the classic test is the McMurray test, and how that's done is done with the patient lying down, and you flex and extend the knee, and you load the joint compartment pointing toward the injured meniscus. So if the medial meniscus is injured, then you actually point the heel toward the inner aspect of the knee as you flex and extend the knee. And if it's the lateral meniscus is injured, then you point the heel toward the outer aspect of the knee. And patients will feel pain, and the classic McMurray test is with a patient will have a click or thud as you flex and extend the knee. So most of these, of course, in the younger people are treated arthroscopically, and you guys are aware of how this is done. The scope is placed generally in the lateral aspect of the knee and operating instruments medially, and then use a small instrument to remove the torn piece. And you generally try to, of course, preserve as much meniscus as possible, since it is an important function. Now, if the tear is in the more peripheral aspect of the meniscus toward an area where there's good blood supply, then they can be repaired. And you can see that the blood supply to the meniscus is all pretty much periphery, all in the capsular area. And so if the tear is isolated to this area, then it can be repaired with sutures. tears that are more in this white zone where there's not good blood supply are not amenable to this. And if you repair one of these and do a good job, the chances of them healing is usually about 80%. And this is just a slide of how that's done, and it's all done arthroscopically. The next thing I'd like to just touch on is ACL tears, and again, this is a slide that shows the ACL and the femurs up here and the tibial plateau down there, and you can see that the ACL has two bundles. There's an anterior medial bundle and a posterior lateral bundle, and of course these injuries usually occur as a result of sports-related injuries. And generally speaking, the mechanism of injury, the patient will say, well, they planted their foot and then they changed direction very quickly or pivoted very quickly, and or maybe their knee buckled when they hyperextended it. The other type of injury that can occur, of course, is direct blows, such as when an individual is playing football and is hit from the side or tackled. And the mechanism of injury in people who are doing football and basketball are a little bit different. For your skiers, for you guys that ski, usually how an ACL is torn in skiers is that the person skiing loses balance and their weight gets back on their ski, and then the ski will accelerate forward, and causing the tibia to translate forward, and this can then tear the ACL. And at the same time, the quadriceps may contract, and this can further stress the anterior cruciate ligament. So when a patient comes to the office and they've sustained an ACL tear, usually they'll say that they've felt a pop in their knee. 75% of these will have rapid onset of swelling or hemarthrosis. 50% have associated meniscus tears. And the classic test for this, there's other physical findings that patients will have with an ACL tear, but the classic test to demonstrate instability is a Lachman or Lachman maneuver, and that test is done with the patient lying down, and you stabilize the femur and then place an anterior force on the tibia, and generally speaking, then the tibia, of course, will move forward on the femur, and if it does so more than 5 to 7 millimeters, that's indicative of an ACL tear. And we have a little instrument in the office called a KT1000 that we can use to quantitate this even better. These are generally treated surgically in the younger active people, but in patients middle-aged or older who are not particularly active, they may do just fine with physical therapy, short course of a brace and such. The patients can have very strong what we call secondary stabilizers, such as the collateral ligaments, posterior capsule, that can act to substitute for the ACL. But again, they're generally treated surgically in the active people, and age is not generally a contraindication. So if you have someone over 50 and such that plays tennis and skis and so forth and feels they need to have a stable knee, they would be a candidate to have their anterior cruciate ligament fixed. Your female patients, keep in mind that there's a 3 to 6 times greater risk of an anterior cruciate ligament tear in a female athlete versus a male athlete. And this is probably related to the fact that the cross-sectional diameter of the ACL in a female is somewhat smaller than that of a male. They also have a smaller intercondylar notch space, so that if an injury occurs to the knee, the ACL can butt up against the bone of the intercondylar notch. And the other factor which may play a role is that in females there's thought to be a greater disparity between the strength of the quadriceps and the hamstring, so that the hamstring doesn't act to protect any anterior displacement of the tibia against the femur. So if you have an ACL tear, these ligaments can't really be repaired, generally speaking, because the tissue becomes frayed and it's just not amenable to being sutured. So you have to substitute material for it, and the most common thing is a patellar tendon graft, and usually we do autografts most commonly, and certainly in younger patients. In the older people, may do an allograft. And the options then are the patellar tendon graft or a hamstring. And the hamstring, of course, is the semitendinosus and gracilis. And this just shows how that patellar tendon graft would be taken, usually through a smaller incision than this, and you have some bone blocks on the end, generally about 2 centimeters at the patella and at the proximal tibia. And then you put sutures through the graft, and it's passed through the knee to substitute for the ACL. And here's how the hamstring graft appears once it's been harvested. And that graft is taken through a small incision, the upper tibia, and you have a tendon stripper to remove the tendon. And again, then you have this, you remove the muscle, put sutures in the end of it, and then pass it arthroscopically. And this is done, you know, generally as an outpatient procedure, and people usually do quite well with this, but the recovery actually is fairly quick and early on, and patients can get back to walking, biking, swimming, and so forth within a few weeks. But in terms of going back to aggressive sports, it's generally 6 to 9 months, and maybe longer with the use of allograft tissue. The next thing I'd like to talk about is knee arthritis, and this is probably the most common thing you see in your office, and it's certainly the most common thing that I'm seeing in my practice right now. And 70 million people in the United States have some form of arthritis, and most, of course, suffer from osteoarthritis. There's certainly a genetic predisposition to this, and also it's associated with obesity and previous knee injury. Genetic aspect is kind of interesting because it is actually more of a genetic predisposition to hip disease than knee disease. And if you look at the Asian population as an example, the risk of a patient developing significant hip arthritis is less than 1%, whereas in the European population, about 7% will actually develop significant hip disease and require possibly a hip replacement. So what's the causes of arthritic knee pain? Well, the normal knee, of course, has articular cartilage, which protects the underlying bone, and the bone is highly innervated. The cartilage provides for smooth joint movement. If the knee becomes diseased, then the cartilage becomes rough, of course, and this results in increased friction, inflammation, and then maybe bone-on-bone wear. And as the cartilage is fully worn away, then, of course, the sensory nerves of the bone are very exposed, and this is a very painful condition. In diagnosing knee arthritis, certainly the diagnosis are generally done based on physical exam and the patient's history. Imaging studies are important, but I'd just like to emphasize that in most instances all that's needed is x-rays, and the important x-ray is probably a standing x-ray, which will show the loss of joint space. And so in my practice, I'll do a standing view, a lateral view of the knee, and then a patellofemoral view. And so an MRI scan in most instances is not needed. Probably the MRI scan is really indicated if you're not quite sure of the diagnosis, or if the patient's, let's say, has normal x-rays and is an older individual and having locking, giving way of their knee. Bone scans rarely needed in diagnosis of arthritis. I'm going to just mention a few things in the medical management of arthritis. The first thing is weight loss. The average American is 20 to 40 pounds overweight, and the average person takes about 5,000, 7,000 steps a day. So the forces generated across the knee joint, and if you consider that the forces generated across the knee joint are several times body weight, you can have somebody lose a few pounds. It can make a big difference. The thought is that going up and down stairs, fast walking, and so forth, that people that generate about 5 to 6 times their body weight. And this is a significant problem. I know it is for me. I don't know if it is for you, but like I'll see people that come and see me in their office, and their BMI is 30 to 40, and they're morbidly overweight, and they come in and they expect me to wave my magic wand and solve their knee pain. And I think that if these people can lose weight, it really can make a dramatic difference over a period of time. So exercise program is important. I mean, and you guys are aware of this too, but if you strengthen the muscles around the knee, particularly the quadriceps and the hamstrings, this protects the underlying knee joint and protects any worn surfaces. Also, flexibility exercise is important because if the patient has better movement, the forces which are not concentrated in such a small surface area. So if the patient can move their knee better, that also can decrease their pain. So, and in addition to that, if a person does come to surgery, if they have better range of motion, better strength, they're likely to do better with surgery. And there's several studies that have shown that moderate exercise doesn't worsen arthritis. So if somebody does have a worn knee, there's no reason that they can't do a moderate walking program, swimming, bicycling. Medication, you just touch a little bit on that. I mean, in my practice now, I try to use the anti-inflammatories less than I did in the past, and try to use it maybe for a short-term basis, 2 to 4 weeks. I think Celebrex is a good medication. It's gotten a bad rap in the past, but I think that it does work quite well, and probably might be superior to the COX-1 anti-inflammatories. Glucosamine, chondroitin sulfate, these of course occur in the body naturally. They're vital to normal body, to normal cartilage function. The studies, as you know, are very mixed on their efficacy. There was a study done by the NIH about 6 years ago, and it was called the GATE study, and they put several hundred people on glucosamine, chondroitin sulfate, and compared it to people on placebo, and they did find that it helped. There's no significant side effects, so you know this is something that sometimes you might want to try, or at least is one option. I usually have people take 1,500 milligrams of glucosamine in divided doses a day, and about 1,200 milligrams of chondroitin sulfate. Injection therapy, I mean, I think corticosteroids will give you the biggest bang for your buck, so to speak. But, I mean, if someone comes in with an acute flare of arthritis, I think corticosteroid injection is very, very helpful. Hyaluronic acid, I mean, now hyaluronic acid, how it works is that the viscosity of an arthritic, of the synovial fluid in a patient who has arthritis becomes reduced. So hyaluronic acid will improve the viscosity, and it also has been shown to act as an anti-inflammatory and an analgesic. That being said, I don't think it really is that beneficial for people with advanced arthritis. It works better in people who have mild arthritis. And you know, I have patients who respond quite well to this, and if that's the case, I might repeat that a couple of times every 6 months to a year, but it's an expensive item. Protein-rich plasma and stem cell injections are being done now. This is really a purely, I think you have to consider this as investigational. You know that athletes are going to Europe, for instance, or they're going to special clinics and getting these injections, but there's no literature that really supports their use. They're very expensive. There's a clinic in Carlsbad that's doing PRP injections and stem cell injections, and the cost is $1,500 to $2,000. It's all cash and carry. Insurances don't cover it. Stem cells, of course, protein-rich plasma comes from blood sample that you centrifuge down and use the sediment then to inject. Stem cells are generally taken from an iliac crest aspiration. There's a study, a surgeon in Korea that's doing this, taking the stem cells from fat cells from the buttock, which is would certainly be something people would be more likely to want to have done. Another thing, unloader braces, you've heard that term. What an unloader brace does is it moves the forces from a worn part of the knee. As an example, let's say that the medial aspect of your knee is worn. You can use the unloader brace to displace the forces to the lateral aspect of the joint. And that can sometimes help people, but these are somewhat cumbersome, they're expensive, and a lot of people just rather not wear them. And then simple knee brace, all it does is provide a little generalized support and maybe some warmth to the knee. And I'll use walking aids like a cane to maybe to normalize a patient's gait if they're not a good surgical candidate or don't want surgery. At least it protects them from having compensatory injuries to another joint. Also, a walker is good to help certainly prevent some patients from falling who, again, aren't good surgical candidates. So just going on briefly about knee replacement surgery. The knee replacement surgery involves removing the damaged surfaces of the joint. So you're taking away about 8 millimeters to 10 millimeters of the distal femur and the proximal tibia and replacing that. It does work well if you select your patients well and do the surgery appropriately. There's 625,000 knee replacements done in the United States today, and this number is expected to triple in the next 15 to 20 years. This is going to present a significant financial burden to the healthcare community, and there's a concern there's going to be enough well-trained surgeons in the future to actually do this operation. So that being said, as you all know, you're just removing the surface of the joint. I mean, it's not, and the femoral component is generally metal. as is the tibial base plate, and then the plastic insert goes in. And I tell patients that the plastic insert's kind of replaces the cartilage, which has been worn away. Partial knee replacement. This is done where the disease is isolated to one part of your joint. So if the medial aspect of the knee is worn, then you can remove the worn medial joint compartment and resurface that. It works well, but you really have to select your patients properly. If you have significant disease, let's say in the lateral joint compartment or the patellofemoral joint, it's probably not going to go well. It's also a bit of a harder operation to perform than the total knee, so you have to do it properly. You have to balance the ligaments properly. But let's say that you do the operation well, you select your patients well, the outcome should be the same as the total knee, and it should last. The 10-year survival rate is the same, and these haven't been out there as long as total knee, so we don't know whether how they're going to do over 15 to 20 years. So you can also do a patellofemoral replacement. If a patient comes in and has significant patellofemoral pain, you can just resurface that area. And knee surgery is doing better. At Tri-City, we've really been trying to make some improvements in, for instance, pain management. We're doing blocks and using newer analgesics, trying to get away from narcotics as much as possible. The implants are better. The bearing surfaces are better. The metals are better. The plastics are better. The plastics are cross-linked with X-rays, so they last longer. We're doing some things with vitamin E, adding to the plastic, which is an antioxidant. The implants come in better sizes. We're also doing things to reduce blood loss. Tranexamic acid is an anti-fibrolytic agent, and we're giving that to the patients. Dr. Cooperman does that with his hips, and I do that with my replacements. And it does reduce blood loss. We're using a device called an acomatus, which is a bipolar sealer that seals the vessels before you cut them, and all this can reduce blood loss. Many of us are doing computer navigation. That makes your cuts more precise, and it also, you don't have to put rods in the femur and tibia, so reduce blood loss. And so with all this, you have faster rehab and reduced hospital stay. Vitamin E, Tri-City offers this. Vitamin E is a natural occurring strong antioxidant. It's blended into it can be blended into the polyethylene or plastic. And one of the causes of failure of total knee replacements is that the plastic can oxidize, and then with this it can wear and wear quicker than it would otherwise. And so in the laboratory, adding vitamin E to these polys decreases wear, and we're hoping that in the patients then it will allow these implants to last longer. So the results of knee surgery is generally, like hips, good. It's most patients do well. I think the recovery is tougher than hip replacement surgery. These people have more pain the first few weeks, but once they get through that, they generally do well. And certainly with smaller incision, modern antibiotics, and all these other things that I referred to previously, patients generally do quite well. And I think the success rate is in the range of 90 to 95%. And that means that patients have pain relief, they have improved mobility, and they do return to most activities. I have to say that even though the majority of these patients are happy, I don't think that that the science of total knee replacement has quite reached that of hip replacement surgery. So some of these people don't feel quite as if their knee they don't feel like they have a normal knee. A few of them will feel a little clicking. They may have a little discomfort at the time. But the improvement from where they were prior to doing the procedures is generally pretty significant. So that's all that I have. Thank you.